So hello everyone, welcome to this week's Grand Round. I'm Ben, one of the cardiology registrars, joined the Trust in October. I'm just going to briefly, talk about out-of-hospital cardiac arrest and sort of some of the current evidence that there is and how that's changing. So obviously this is a classical picture of an out-of-hospital cardiac arrest. Someone unfortunately collapses to the ground and hopefully a well-meaning bystander calls for help and initiates some CPR. And then obviously a whole series of things happen before they arrive in hospital. So we're going to talk a little bit about the sort of epidemiology and mechanisms behind cardiac arrests, the whole process from the moment they collapse to coming to hospital and the treatment that we usually give here. And I'm going to focus largely on that as part of the talk, and then talk a little bit about the recovery and how things are going to potentially change in the coming years. So in order to contextualize this a little bit, I'm going to have a case that's going to sort of run through the talk. So imagine that you're one of the on-call members of staff for the resuscitation team. So you could be part of the medical on-call team or the intensive care or anaesthetic team or A&E. And you often will get one of these calls come in saying someone's collapsed, they're found unresponsive, they've had some CPR and they're on the way to the hospital. So in this particular case, is a 68-year-old gentleman who was found to be in VF when the ambulance arrived on scene. They delivered CPR and had to give 2 shocks with one lot of adrenaline before they achieved return of spontaneous circulation. And then they're conveying him to the hospital as we speak. So while we go through the case, I just want you to have a little think about what you think might have happened in this case. If you were on call or you were going to receive this person, what would you think are the most important things to do for them as they arrive in the resuscitation room? What's the sequence of events that you think are important? And how are we going to sort of help this patient survive this obviously significant sort of acute illness and insult? So just to talk a bit about the sort of epidemiology. So the definition of a cardiac arrest is a sudden circulatory failure due to loss of systolic function, cardiac systolic function. And just to give you some sort of data, so this is pre-pandemic data, so sort of normal life data before all this has been going on. In 2019, there was 80,000 suspected calls put out to the ambulance services across the UK, across England, of which approximately 60,000 were deemed to be true cardiac arrests. I haven't dug deep, but I presume that the following 20,000 potentially haven't lost output, but merely have had a faint or something similar. And of the 60 or so thousand who've had a true cardiac arrest, only 31,000 of them, or about half, receive sort of CPR from the ambulance crew. And they managed to revive or partially revive about a third of those. So a bit more than 10,000 patients are going to be conveyed to A&E departments across the country in England with return of spontaneous circulation. Unfortunately, though, still the outcome is poor, and fewer than 1 in 10 of the cases will survive to hospital discharge, which is obviously quite a low number, but I think that's 1 in 10 from the original 60,000 who collapsed. And there are some things that we already know, but it's important to put them in so we don't forget them. That immediate CPR, good quality CPR, can increase the survival 3 to 4-fold, and that use of a defibrillator within the first 3 to 5 minutes can also dramatically increase the survival. And that's why there's an ongoing campaign about having defibrillators available in sort of sports centres and shopping centres and everything like that. But still, there's obviously much room for improvement, and it carries a significant morbidity. So because of this, the morbidity and mortality of this, in 2017, there was a review held and in which they've tried to set up a national framework for out-of-hospital cardiac arrests in England, and they've called it the Resuscitation to Recovery Framework. And this is the front page of it. Obviously, it shows that the important thing is recognising the symptoms of the collapse and calling for help, effective CPR early, defibrillation, and then hospital care for the post-resuscitation period. Unfortunately, the work by this network's kind of been stalled a bit by the pandemic and is kind of stumbling along in the background, and will kind of pick up again in the next couple of years. So I suppose the important thing to think about as hospital professionals is when one of these patients arrives, they've had their CPR, they've got return of spontaneous circulation, hopefully they won't go back into arrest, but what can you do to prevent that, and what can you do to help them survive? So you need to think a little bit about what the underlying mechanisms and causes of that might be. So, most cardiac arrests are caused by one of these four causes, one of these four mechanisms rather, which obviously point largely to a cardiac cause, but obviously lots of these problems can themselves be caused by non-cardiac issues in certain circumstances. So common risk factors for suffering a cardiac arrest is coronary artery disease, either acute or chronic, left ventricular dysfunction, so particularly reduced ejection fraction heart failure, cardiomyopathies such as hypertrophic cardiomyopathy and arrhythmogenic cardiomyopathy, and then the channelopathies. So those are kind of lots of the cardiac causes, but there are of course non-cardiac causes, including sort of any medical or surgical and emergency that causes significant biochemical derangement. So obviously if you've got profound hypoxia that is persistent, you're going to get organ dysfunction, including cardiac dysfunction. If you've got inadequate circulating volume, or if you've got something that affects the mechanical function of the heart, such as a tension pneumothorax, then those things can affect it. And also, you can also have sort of trauma, sepsis, all these things I've listed here. Once the patient arrives and you're thinking about all these different things, they need to receive sort of the post-resuscitation care. So once a patient reaches hospital, there is very variable outcomes as to which patients are going to survive, and there's not very standardized care for trying to maximize patient survival and minimize morbidity. So thinking about our patient who's coming in, again, if we just think about what we should do when they arrive in hospital. So a little bit more information about the case. So this is I've made a mistake there. 68-year-old gentleman, as I said, out of hospital cardiac arrest, return of spontaneous circulation after 2 shocks and some adrenaline. On arrival in the emergency department, he's got a blood pressure of 140/80 millimeters of mercury with a heart rate of 110 beats per minute. He's got spontaneous respiratory effort at about 14 per minute, and saturations of 97% on 10 litres of oxygen. The ambulance crew have used an eye gel to secure his airway in transit, and he's got a GCS of 3 on arrival. The ambulance was in transit to the hospital for 25 minutes. And here they are, they've arrived, and they're about to give you this, they're giving you this handover, and you're going to take over the patient. So I'll give you a bit more background. This gentleman was at home with his wife. He was in a different room to his wife, and she heard a loud bang and, worried about what had happened, went into the living room and found him on the floor. He'd been sitting at a table. Unfortunately, he was partially under the table when she found him, and he was unresponsive. She called 999 almost immediately, and they instructed her to deliver CPR. But unfortunately, she found this very difficult because he was partly under the table, and she couldn't really get good access to him. About 10 minutes later, the ambulance crew arrived, and they pulled him out front of the table and delivered textbook CPR, attached their defibrillator, and, as we've said, given him the shocks to get the return of spontaneous circulation, probably approximately a further sort of 6 minutes later. In terms of his past medical history, he's got hypertension, alcohol excess, drinking approximately 15 to 20 units per day. He's visibly obese and is an ex-smoker. In terms of his medications, he takes irbesartan and amlodipine, but no other medications, and he's not got any allergies. He's a retired builder, and otherwise he's considered to be independent, although unfortunately his alcohol excess has been progressing over the last number of years. So if you all just think about what you would prioritize as your sequence of events now. So routine, they've given you the handover. A good thing to do would be to dispatch somebody to take the collateral history from the wife, either over the telephone or in person, depending if she's there, to gather that information that I've just given you, because much of that will come from her, and obviously to look up on the hospital records, see if there's any relevant information. And then, of course, it's transferring onto the A&E trolley and doing a sort of A to E assessment. You'll have anaesthetic and intensive care teams working on the airway, potentially securing that. He's obviously needs to have good access to deliver resuscitation in case he becomes hemodynamically unstable. And he then needs sort of urgent investigations of what the underlying cause might be. So sort of post-resuscitation care includes temperature management, vital organ support, and investigation and treatment of the underlying cause. The difficulty, of course, in lots of these cases is that the underlying cause is not immediately obvious, and often there's very limited history. So this patient collapsed sort of unwitnessed, or they're in the house with someone else, but a large number of outsourced cardiac arrests are unwitnessed. It's difficult to know how long they've been collapsed for, and there's no preceding history to let you know whether they suffered any symptoms shortly before they collapsed. So one of the really important things to do, of course, is to do a 12-lead ECG, send off blood gas, send off blood tests, get a mobile chest X-ray, and you can get all that done very quickly in the resuscitation department. So if our ECG on this gentleman was this, just give you all a moment to look at that. So as I'm sure you can all see, this ECG shows ST elevation in leads 2, 3, and AVF, with some reciprocal ST depression and biphasic T waves in V2, 3, and also in AVL. And there's beginning of broadening of the QRS in V1. So, you know, this ECG demonstrates an inferior ST elevation myocardial infarction. And so the priority in this case would be to appropriately stabilize and resuscitate the patient, but may arrange immediate emergency transfer to a cath lab that could do angiography and potentially deliver PCI if necessary, which it probably would be looking at this ECG and thinking about this history. So if you're not in a hospital or in a centre that has cath lab capabilities, you need to dedicate somebody to arrange that immediately. You need to blue light transfer them, and ideally you should get this 12-lead ECG before the ambulance crew leave, because one option is just to put him back in the ambulance he's come in and send him to a centre that has that capability. So just quickly to go over the criteria for an ST elevation myocardial infarction on the ECG, you need greater than 2 millimeters of ST elevation in 2 or more precordial leads, so that's V1 to V6, or 1 millimeter of ST elevation in the limb leads. And in this case, you've got reciprocal depression, but you don't have to have that. And then there are some equivalent ECGs that aren't obvious to everybody, but are also worth considering, especially in an outsourced cardiac arrest. So we'll talk about those in a second. But the current guidelines, as I've just said, across Europe and in the States and across most of the world, is that patients who've had an outsourced cardiac arrest who've got ST elevation on their ECG need to go straight to a cath lab as soon as possible, doing what you need to do to ensure that they don't, unfortunately, go into cardiac arrest and transfer. So briefly to talk about sort of ST elevation equivalent ECGs, there's bundle branch block ECGs, which lots of people are familiar with and often become quite concerned that a new left bundle branch block or an unknown if it's new left bundle branch block may herald an ST elevation myocardial infarction. In cases with alpha hospital cardiac arrest, when the patient's usually unconscious, it's important to scrutinise the ECG very closely and think about that. But in a well patient who doesn't have chest pain, that's usually not the case. It's not usually a silent myocardial infarction. And then there's a few other special scenarios to be aware of. Paced rhythms tend to give you left bundle branch block and have very difficult to interpret ST segments. So usually you can't gain much information in terms of ischemia from those ECGs. And then there's posterior MIs, which is demonstrated by the ECG at the top right-hand corner of the screen there. You've got deep ST depression in V1 to V3, and you can see that they've put on leads V7, 8, and 9, which wrap around the back in the fifth intercostal space, and you can see clear ST elevation in those leads. So that's a posterior myocardial infarction. And then there's a ECG on the bottom right, which is suggestive of left main stem acute occlusion, and there is ST elevation in AVR, and then there is reciprocal ST depression of at least 1 millimeter in more than 8 leads. So you can see that in certainly V3 to V6, and then also in lead 1, 2, and potentially an AVF. But so you need 8 leads or more of ST depression with ST elevation in either AVR or V1, and that can suggest left main stem occlusion. So in those cases where you scrutinise the ECG, the answer is relatively straightforward. They need to go to the cath lab, stabilise them, potentially initiate antiarrhythmics if they've had unstable rhythms, especially in transfer, and get them to the cath lab. But in our case, of course, just to be a bit more challenging, the initial ECG demonstrates this. So again, just to describe it to everyone, but I'm sure you can all recognise it, it's a left bundle branch block ECG with a broad QRS, which is negative in V1 and positive in V6, with a RSR pattern in both V1 and V6. There's also left axis deviation. Now, of course, this gentleman unfortunately didn't have an old ECG on his medical record, and so we had no idea if this was new or old. So, of course, there has to be reasonable suspicion of ischemia given the clinical context. But the ECG can, as we've just touched on, be scrutinised for ischemic features. So just to briefly go over them with this ECG, you need ST elevation in the opposite direction to the QRS, with a negative QRS, that is, of more than 5 millimeters in 2 or more leads. And if you look at this ECG very closely, there's not actually 5 millimeters of ST elevation in V1 or V2 or in lead 3 or AVF. So he doesn't meet that criteria. And then there is no significant ST depression in the same direction as a negative QRS. So there's no ischemic features there. And then there's also no ST elevation in the same direction as a positive QRS. So concordant ST elevation. And a final criteria, which isn't actually in the ESA guidelines that I showed you, is a prominent positive R wave in V1 to V3 can also be suggestive of acute ischemia. So this ECG doesn't have any ischemic features at all, and it shows a sinus tachycardia. So this poor patient falls into an unclear group. So he doesn't meet the STEMI criteria, so he's not going to go straight to the cath lab. So the conundrum is, what do we do with such patients? And for a long time, there was quite a strong vogue towards taking pretty much all outsourced cardiac arrest patients to the cath lab, and certainly ones with, for example, in this case, left bundle even if it doesn't look particularly ischemic. And there's various studies across the years, but I've just quoted one there, an observational study that was done in 2012 showed a significant mortality benefit in taking patients immediately to the cath lab. So 34% of patients died if they went straight to the cath lab, whereas 46% of patients died if they had a delay in going to the cath lab. So for a while there was an argument, or there was a sort of a thought that all of these patients should go to the cath lab. But if you look at sort of the studies more broadly, I'm not going to go through all of these, but these are sort of observational studies that were carried out in the last 10 years. And there is fairly mixed results. So if you go through these, 4 of these studies showed that there was no benefit at all. A couple of these studies sort of had a leaning towards benefit, but it was a bit unclear. And then several of these studies showed that there was a benefit. So of course, these are all observational studies, and unfortunately, they're very prone to bias. It's very difficult to know what the sort of contributing factors were to the good outcome patients versus the poor outcome patients, and things are done in a relatively uncontrolled fashion. So it's very difficult to rely on this kind of data. So in this sort of mixed data field, a few randomized control trials have been published in the last couple of years that are worth talking about. There was the COAX trial, which was published in 2019, which essentially looked at all patients who had outsourced cardiac arrest who made it to the hospital, who didn't have a STEMI on their ECG, because those patients go straight to the cath lab, and didn't have another obvious cause for their arrest, such as trauma, where it was very clear why they had arrested, and they weren't in overt levels of shock, which is another good indication to go to the cath lab, cardiogenic shock. And they looked at 2 different groups: immediate angiography versus delayed, after there was time to assess neurological recovery in the ICU. And then reasons to move from the delayed group before you had your neuroprognostication in ICU were the development of cardiogenic shock, or the development of life-threatening arrhythmias, or evidence of ischemia, which could either be a very elevated troponin, for example, or regional wall motion abnormality on an echocardiogram. And then the patients who went to the cath lab, the method of revascularization was either stenting or bypass, depending on the sort of preference of the anatomy and the center. So interestingly, in this study, they found an acute thrombotic occlusion in only 3.4% of the patients who were in the immediate angiography group, but in 7.6% of the patients who had delayed angiography. And approximately 15% of the overall cohort, both groups put together, had an acute coronary lesion that looked like the culprit cause for the presentation. But nonetheless, PCI was performed in 33%, or a third of those who went for immediate angiography, but only a quarter of those who went for delayed angiography. And there was reasonably similar amount of bypass grafting done, about 6% in one group and nearly 9% in the other group, the delayed group. There was some loss to follow-up, but an intention to treat was used, so hopefully didn't affect the analysis too much. And just importantly, it's worth noting that life-sustaining treatment was withdrawn in a very similar amount of patients in both groups, so just over a quarter in both groups. So the overall sort of headline result was that at 90 days, 64.5% of the immediate angiography group versus 67% of the delayed group had survived. And this is the graph just to demonstrate that. So there's a few interesting things to say about this study, that it had a high degree of survival. Nearly 2/3 of patients surviving an admission without hospital cardiac arrest is a high proportion. In some centres, the survival is more like 10 or 15%. But obviously, this was a selected group in a trial setting, and that a lower proportion than had previously been seen in other studies, albeit that most of the previous studies were observational, had a culprit lesion or had an acute thrombotic occlusion. This is usually reported at being around 40% of patients who've got at least a culprit lesion and require PCI. There were some limitations of this study. It was an unblinded study due to the nature of the study of going to the cath lab or not. They had very strict inclusion and exclusion criteria, which makes it very difficult to apply the outcome data to the treatment and outcome data to your own patients who are coming in unselected through the emergency department. 2.5% of the patients withdrew from the study, which, given that the study was large but it wasn't massive, 550 or so patients, can affect the outcome data a bit. But nonetheless, it was very thought-provoking results to think that potentially there's no survival benefit in going straight to the cath lab if you don't already have an ST elevation MI syndrome on your ECG. So this was followed a couple of years later by the Tomahawk trial, which was reported earlier this year in 2021. It was actually very similar. So they recruited just over 550 patients. Their patients were between the ages of 30 and 75, whereas the COACT patients were 18 to 75. And again, they excluded all those with STEMI on their ECG because it's well understood that those go straight to the cath lab. Importantly, this trial included both shockable and non-shockable rhythms because the COACT trial only included shockable rhythms. So the COACT trial only included patients who had either VT or VF when they required resuscitation and they got return of spontaneous circulation. So all those with PEA and asystole were excluded, which may well affect the type of cardiac arrest that you're seeing, or rather the cause. And in the COACT trial, the patients were all comatose with a GCS of 3, whereas that wasn't an exclusion criteria in the Tomahawk trial, although essentially almost no patients had capacity, but some of the patients did have some degree of GCS, so they had some consciousness. And again, they compared immediate angiography versus delayed angiography. And delayed angiography in this trial meant more than 24 hours, but it was not quite as delayed as in the COACT trial, where they were aiming to wait for neuroprognostication, which can often take up to 3 days. And again, you could change from your delayed group into your early angiography group, so have your angiogram earlier with a view to potential PCI if you developed cardiogenic shock or you had dangerous arrhythmias that were thought to be due to ongoing ischemia, if you had a dramatically elevated troponin, so that's 70 times the upper limit of normal, which on a normal assay would be around 1,000, which had to be recorded at least 6 hours after you had the cardiac arrest. But similarly, the angiogram could be delayed or even abandoned if a non-cardiac cause became quite likely or probable. So not every patient needed to go to the cath lab in the delayed group. The primary endpoint was death from any cause at 30 days, and there was a composite second endpoint, which was death from any cause or severe disability. So angiography was performed in 95% of those who had immediate, were randomized to immediate, whereas it was only 62%, so a bit less than 2/3 in the delayed group. Of the people who didn't get angiography in the immediate group, half of them, so 2.3 or so percent of them, died before they could reach the cath lab. And I presume that another 2.3% were potentially unstable to reach the cath lab. Slightly strangely, 8% of those in the delayed group ended up having an early angiogram, and the reason was unclear when the cases were reviewed. So whether that was a deviation from the trial protocol is not really clear, which can sort of slightly challenge the results. But anyway, the median time to angiography was 3 hours in the immediate group versus 47 hours in the delayed group. And there was a very similar prevalence of coronary artery disease, about 60% in the immediate group and 70% in the delayed group. And that difference was not significant. And a culprit lesion was identified in 38% of those in the immediate group versus 43% in the delayed group. Again, that difference wasn't significant. And these findings are much more consistent with previous studies. And as I said, that might be due to the fact they included those patients who had PEA and asystole rather than just arrhythmogenic, shockable cardiac arrest. So revascularization, as you'd expect, given the culprit lesion percentages, was 37% in the immediate group, which is pretty much everyone who had a culprit lesion, and 43% in the delayed group, which is, again, all of the patients who had a culprit lesion. And then looking at the sort of overall result, 30-day mortality was 54% in the immediate group versus 46% in the delayed group, and the hazard ratio at 1.28, and the confidence interval just touching 1, so not quite statistically significant, but trending towards potentially a more increased mortality in those patients who went for immediate angiography. And looking at both groups, the majority of patients died from severe hypoxic brain injury or circulatory collapse, and actually most of them were from severe hypoxic brain injury. It's almost 3 times, they were almost 3 times more likely to die from severe hypoxic brain injury than they were from circulatory collapse, those patients who died. And looking at the composite outcome of death from any cause or severe neurological deficits, that's severe disability and dependency or death, 64% in the immediate group versus 46% in the delayed group. And again, that confidence interval just touches 1, so it didn't quite reach statistical significance, but there was a trend towards increasing levels of either death or disability in the immediate angiography group. And again, this is just a graph to illustrate that fact, and you can just see them separating quite early and then maintaining a fairly steady level of separation up to 30 days. So just to think about both of these studies, they showed sort of similar results, although this Tomahawk study showed a trend towards harm. It included better patients who were more representative of the mixed cohort of patients that we see in the A&E resus after resuscitation who don't have ST elevation. I suppose it's worth thinking about what the potential mechanisms as to why revascularization might not confer a mortality or morbidity benefit. I suppose one of the things to think about is that only 38% of those patients who went straight to the cath lab had a culprit lesion, which means that 62% of patients didn't. So whatever benefit the 38% gain from angiography, the 62% who don't receive any kind of treatment because they don't have a culprit lesion don't gain any benefit from angiography, but they do potentially suffer the consequences and the risks of the procedure. So that's the transfer time, the contrast given on the table, vascular complications of vascular access, for example, potentially other complications, although they're rare, such as aortic dissection, coronary dissection, arrhythmia on the table, stroke, and then again transfer from the cath lab back to the ICU. But I think it's also important to think that all of those 62% of patients who don't have a culprit lesion, those patients have delay in their investigation and treatment of what the other underlying cause might be. Which is why, given the sort of heterogeneity of the group, it's difficult to see a benefit. So just to quickly look at the limitations of the Tomahawk trial. Again, it was an unblinded trial, and if you were excluded if you had hemodynamic or electrical instability, ST elevation, and so those patients it doesn't apply to. 4% of those who were randomized withdrew or failed to meet the criteria, which slightly challenged the power of the study. And it was only a short trial, only over 30 days, whereas the COACT trial managed to report outcomes over 90 days, which is a bit more useful, gives you a bit more reassurance. But again, both trials are relatively short. And the benefits of early revascularization may not be seen in such short follow-up, such as LV function recovery and prevention of heart failure. So I've already talked about some of these points already, but putting these two trials together, they're both about 550 patients. They both were a bit underpowered to reach significance. Less than 30% of the patients in either trial were women, so it's difficult to apply these findings to female patients who are less represented in the alpha cardiac arrest cohort anyway. Both studies showed a delay in reaching target temperature. Whether or not that's significant or has relevance in the resuscitation and the recovery period is unclear from the literature and is a topic for another day and not something I'm particularly expert on, but that nonetheless was reported. But looking at both of the trials, it seems that if there is an equivocal ECG and then delaying angiography until there's been some neurological recovery is a justifiable step to take. But there is probably a subset of patients who actually would benefit from urgent angiography, and identifying these patients is difficult, which is why, of course, the criteria for developing cardiogenic shock or arrhythmia or having evidence of regional wall motion abnormality on echocardiography helps decide on whether those patients actually should be moved from the delay into the early angiography group. So coming back to our case, as there was no ischemia on the ECG, patient was hemodynamically stable, was in sinus tachycardia, there wasn't any ongoing arrhythmias. The decision was taken to stabilize the patient, transfer them to the intensive care unit for further investigations, and to see how things developed. They had obviously airway secured and ventilated, blood gas and blood tests sent off. They went straight to the CT scanner and had a CT head, CT pulmonary angiogram, and CT abdomen and pelvis to look for any cause of the cardiac arrest, and then they were transferred to the intensive care unit. In the following 24 hours, the troponin on admission was 49, but during the middle of the night rose to 1200. And an echocardiogram performed early the next morning showed moderate to severe LV dysfunction with a possible anterior regional wall mesh abnormality, but difficult to interpret in the context of a significant left bundle because you have dyskinetic contraction of the left ventricle. And so after discussion with the cardiology team, the patient was urgently transferred to the cath lab to have angiography with a view to potential PCI if it was necessary. And I don't know if I'm able to play this. No, unfortunately not. You will have to take my word for it that the angiogram was completely normal. It showed wide unobstructed arteries with just very minor atheroma, but definitely nothing that could be causing obstruction or acute coronary syndrome. And there was really no abnormality in them at all. So the patient was then transferred back to the intensive care unit for further management. Looking at some of the other investigations that were done now that we've had the angiography and we've seen that it's normal, there was a transient rise in the ALT to 180, but this settled. The renal function remained reasonably preserved with only very mild AKI developing in a similar time period, and the liver function, apart from the rise in the ALT, was fairly normal. The hemoglobin held for the first 3 or 4 days of the admission, but then dropped slowly over 48 hours to 120, but stabilized at that point. And there was a reciprocal moderate urea rise from about 4 to about 12, which again improved. The CT chest, abdomen, and pelvis showed cardiomegaly, and there was some fractures of the anterior ribs on the right and the left side, which was obviously as a consequence of CPR, which was quite vigorous in this gentleman because he was quite obese, so it was difficult to be certain of achieving good compressions. And his CT head on admission was normal. So thinking about what caused his cardiac arrest is a bit challenging, but briefly I'm going to just talk about shock because it's not sort of a central part of this, but it's cardiogenic shock is the most common cause of death in patients who do have acute MI, and that's why this is often an indication for angiography plus minus PCI in out-hospital cardiac arrest patients. As I'm sure you're all aware, extracorporeal membrane oxygenation performed as VA, so venous arterial, which bypasses both the heart and the lungs, can be used, which is only available in specialist centres, can be used in cases of refractory cardiogenic shock as a temporizing measure, assuming that you're going to find and treat definitively a reversible cause, such as acute coronary ischemia. It's got increasing use across the UK and across the world, and there is increasing evidence base to say that it can improve outcomes in patients who are very unstable, so sort of big, not necessarily out-hospital cardiac arrest, but STEMI patients who come in who are unstable or also in outsourced cardiac arrest patients who arrive with some degree of output, but demonstrating signs of instability, such as refractory VT. There is a growing evidence base to say that it can improve survival significantly. There are ongoing trials in the out-hospital setting, which is obviously where lots of people think maybe it'd be most useful if you arrive at the patient who's arrested and you just immediately restore effective oxygenated perfusion and then decide what to do with the patient. But there's been very mixed results in these studies. I suppose the difficult thing is that these patients are very heterogeneous in their makeup, and so it's difficult to know whether you're going to be able to deliver a definitive treatment or not, because you don't often have time to make any kind of assessment when you arrive at the roadside to deliver the ECMO. And the other thing that's worth bearing in mind is that ECMO is incredibly resource-intensive treatment, especially in the pre-hospital setting. So even if there was some degree of benefit, especially in the UK, where we have obviously the NHS, an essentially funded service which is free at the point of use, it would have to go through a sort of cost assessment. But so just returning to our case, he didn't demonstrate shock, so that's not particularly relevant for this particular patient. He remained hemodynamically stable after weaning off of his noradrenaline. His blood tests were, as we've gone through, normalized. His blood gas on arrival was deranged, as you would expect, with a low pH and a high lactate and low bicarbonate, but that had normalized within about 24 hours of his admission. So they weaned him off his sedation to see how he would do, but unfortunately he had no spontaneous respiratory effort. And then they did, while they'd weaned off his sedation, he unfortunately developed some myoclonic jerks only, but no other evidence of sort of neurological activity. So they sent him for a repeat CT scan, which was done approximately 72 hours or maybe a little bit longer after his admission. And unfortunately, there was loss of grey-white matter differentiation, which was suggestive of a sort of diffuse hypoxic brain injury. So after consultation with the family, it was deemed further treatment was unfortunately futile and care was withdrawn. And he died sort of 6 days after his admission. So obviously it's not a very good outcome for our patient, and unfortunately that's too commonly the case. And one of the things I think we need to think about is how can we better predict the poor outcome patients and differentiate those from the better outcome patients. So this is a thing called the Miracle 2 score, which was recently developed at King's College Hospital and has been validated in a couple of different cohorts and is currently going through further study. But you can see from the score chart there, they basically tried to develop a system that looked at the factors that were most determinant of a poor outcome that could be easily attributable a binary answer, so whether or not they did or didn't happen, and then to develop a kind of scoring system to determine what the level of either severe disability at 6 months or death was based on a score system. So you can see here the key factors are whether or not you had an unwitnessed arrest, if you were in a non-shockable rhythm, if you had unreactive pupils. The older you are, unfortunately, the less favourable outcome you have. If your rhythm changes during the resuscitation, if your pH is low on arrival to the hospital, and the blood gas should be taken immediately on arrival before sort of prolonged and effective resuscitation measures have been taken and rehydration, etc., and the use of adrenaline. And you can see if you've got a score of 0 to 2, your mortality is actually very low, somewhere in the region of sort of 5 to 10%. If your score is 3 or 4, your mortality is probably around 45 to maybe 65%, so it's pretty high likelihood of a poor outcome. And then if your score is 5 or higher, you've got a 90% or higher chance of having either severe disability or death at 6 months. So having this kind of tool available, obviously it doesn't make the decision for you, but it can aid in making the decision. So looking at our patient, his age was 68, which gives him 1 score. He had adrenaline used, which gives him 2, and his pH on arrival was a less than 7.2, which gives him another 1. So his score would have been 4, which would have put him up here in this unfortunately rapidly steep part of the curve, climbing up towards a poor outcome. So those patients who do survive, what is their outcome like if so many of them end up with severe disability? Unfortunately, at the moment, less than 50% of those patients who survive a cardiac arrest and survive to hospital discharge get any kind of follow-up after being discharged. They get sort of very limited access to rehabilitation, very limited sort of mental or physical support in the community. And part of this national review that I referenced earlier is looking at how to better give guidance on exactly what recovery and rehabilitation and follow-up is required, and to set out some sort of minimum standards for what should be delivered by trusts who deal with cardiac arrest patients. And that's something that will be coming forward in the next maybe couple of years. And as part of this sort of review, they're thinking about developing a cardiac arrest centre network, which will operate a bit like the primary PCI network or the trauma network, where patients who've got an out-of-hospital cardiac arrest will be taken not necessarily to the nearest A&E department, but to a department that's experienced in managing these patients and can make appropriate rapid assessment. And that will usually involve having an operating cath lab on site and experienced intensive care unit that has capacity to usually take in these patients, and obviously that 24-hour service. So just briefly to look at that overall message, if you've got ST elevation, you should go straight to the cath lab, and you should have PCI because that's the best way to achieve better end organ perfusion earlier and to achieve better outcome. But if you're one of these people who doesn't have an ST elevation MI, you should be going to an emergency department that's properly equipped and experienced in managing patients in this scenario, have a clinical assessment and an echo, which I haven't talked about in a great deal in this talk, but this gentleman did actually have an echo on arrival. And then if there's a non-cardiac cause identified, then this should be treated. Supportive therapy is important, and potential use of risk predictors to understand the mortality and morbidity of your patient to decide whether your patient should fall into the sort of early angiography group versus supportive treatment group versus potentially palliation group, to be able to better focus treatments. So how can we better provide care for our patients in this scenario? Or by following this algorithm, we can achieve more targeted care to more patients earlier. And that means identifying those who are going to have a good outcome and delivering the relevant treatment to them, not putting them through a period of instability unless it's strictly necessary, but also identifying those patients who are unfortunately going to have a poor outcome in whom treatment is futile, and having family discussions early and making sure that we're keeping patients comfortable and not putting them through undue distress. So just in summary, the important elements of the collateral history and the context around the collapse or the out-of-hospital cardiac arrest, those factors that are on the miracle score or similar factors, and then making sure you scrutinise the 12-lead ECG for STEMI or STEMI equivalents and sending those patients straight to the cath lab, monitoring for signs of arrhythmia or shock or instability, because those patients probably also need to go to the cath lab. And in those patients that don't have any of those things, best supportive care and investigation for other causes such as PE, sepsis, bowel ischemia, and thinking about sort of broader context of the patient's background are important. And in the coming years, we'll probably see the development of the cardiac arrest centre network, which may help to standardise care both in the acute resuscitation setting and the follow-up setting, and hopefully improve outcomes. Thank you very much for your attention, and happy to take any questions. I don't think there's a cardiology consultant on the call at the moment, so I'll just have to field them as best I can. I'm not sure if there's a chat function that I'm not currently looking at, in case anyone's posted any questions.
There is a chat function, but you're receiving some thanks for your excellent presentation, but no questions as far as I can see.
Okay, thanks a lot. Okay, well, thank you. I'll head off.
Okay, thanks, Ben.
All right, thanks, Ollie.